Hello and welcome to this very interesting symposium. We will keep being biased and heavy on the surgical side because we have three exceptional surgeons with us. Unfortunately, the last speaker, who's a physiotherapist, will not be represented, so we'll try to talk not only about who should be operated, but also who should not be operated, and other treatment modalities for patients with hip pain. So first, I'd like to present Lund, a surgeon from Horsens, who will be talking about hip arthroscopy and femoroacetabular impingement.
Thank you. How's the sound? It's okay? So thank you for the invitation. I'll try to talk a little bit about hip arthroscopy and if it's possible for osteoarthritis. This will mainly be on FAI patients. Kjeld will cover the dysplasia patients, and Faris will take all my failures and tell you what he'll do with them. Okay. So first of all, a little bit of basics. Wrong talk. Sorry. I'll make it a little bit easier. I'll just talk about 4 shades of gray. And what do we look at when we look for OA on the X-rays? I use the tennis classification, and you can use others, but for this talk I'll just use this one. It's a grading system, and it's basically divided into 4 grades. And grade 0 is no signs of osteoarthritis, and it might look like this. I'll not discuss retroversion, dysplasia, whatever on the X-rays. I'll just look for the osteoarthritis. Grade 1, they have the sclerosis of the joint with minimal joint space narrowing and osteophyte formation. And grade 2, they start to get small cysts in the head or in the acetabular roof. They start to get a little bit of joint space narrowing. So you can see slight changes on the joint space. And the grade 3, they have advanced osteoarthritis with very little joint space left, or even no joint space left, and severe deformity. So, to the question, is there an indication for hip arthroscopy in the presence of OA? Not when you think hip OA like this. There's not. You see there's no joint space left at all. It's a arthritic hip joint. You might opt for this one. So, but that's not where I want my patients to end up. I don't want to have them end up like this. So let's look at it from my point of view and how I look at the X-rays and the patients. So when you think hip OA, I don't want to look into a joint like this. That was one of my earlier experiences when we operated everyone coming in through the door. We thought we could help all of them. This is one of my very early cases from 6-8 years ago. So this is not what you want to see when you stick an arthroscope into the joint. Severely osteoarthritic. And now she got a hip replacement afterwards. So basically, that's what we want to see, light or slight cartilage changes, hardly any changes at all. When you look at the X-rays, you see 2 layers of cartilage. You have the cartilage in the acetabulum, and you have the cartilage on the femoral head. That's what you see on the X-rays, or you don't see on the X-rays. These 2 layers of cartilage form the space on the X-ray and in the joint. So what we look for on the X-rays, we look for an AP standing pelvis. That's at least what we are using, and that's from some of the research done in Aarhus with Arthroscopy. They did some studies on that. So a standing AP pelvis will tell you a lot of things that you can use for your decision making. We look at the joint space width at the lateral dorsal. So that's how it looks. You look for this place in this part where there's a lot of weight bearing. And I personally, and I think most of the people in Denmark, they don't allow or they don't accept a joint space width less than 3 millimeters if they decide doing a hip arthroscopy. So we also look for cysts in the acetabular roof and other pathologies that might indicate some sort of osteoarthritic changes in the joint. If we're in doubt, we might go for an MRI or a CT scan. If we don't have available, in Denmark at least, the degeneric MRI, so that's not an option for us. My talk will take parts from the Danish Hip Arthroscopy Registry, because that gives us some data that we can I can share with you. The registry was established in 2012, and at the moment there are 11 clinics and hospitals reporting to the Hip Registry. And as of this morning, there are 3,032 procedures registered in the registry. This is the way it works. We have the inclusion. We opt for the patient comes to us and we say we can do surgery on you, and then we do an inclusion, and we do a pre-op examination, and the patient is signed up. They do a PROM preoperatively, and then the surgeon, when he operates the patient, he puts in surgical data and various other things, and that's some of the data I'll show to you. And then we enter 1 year data, and the patient enter 1 year follow-up PROM data, and 2 years and 5 years. The only thing I'll talk about now from the registry is the cartilage changes, damages that we report. And basically, everybody or most surgeons use the ICRS, the classification, which is from the knee joint. You have 0 grade is normal cartilage, then you have nearly normal, then you have grade 2 abnormal, you have severely abnormal, and then you have severely abnormal grade 4 where there's no cartilage left at all, so it's bare bone. But this was from the knee joint. In the hip, it's a little bit different, at least what the thing we decided for in the registry. And we are on the femoral head side, we use the ICRS classification. And it's like this. It's a graded again, like the other one. And this is a grade 4, change from the video you saw before. And in the acetabular side, we use a modification of the Beck classification modified by Conan, and this is from Professor Haddad's group. And that's the classification we're using in the Danish Hip Arthroscopy Registry. And basically it looks like this. You have a grade 0, and then grade 1 is a Malaysia, like fibrillation. You have grade 2 is a debonding, we call the wave sign. You have the grade 3 is the cleavage, and then the full thickness defect. I'll go through them. This is a grade 0 or normal. There's hardly any changes at all. Here you have a Malaysia that's starting to rough a little bit on the edges. Here's very common to see in the hip joint. You have what we call a wave sign. The cartilage is starting to delaminate, and it's getting loosening at the edge. And then we have the grade 3, a cleavage sign at the junction of the labrum. Here's the labrum. This is the joint, and you might end up having a big flap coming loose. And then you have the grade 4 changes with the full thickness loss of cartilage, or maybe even like this, as you saw from the video. But what causes these changes? And that's important. Mostly, in most patients, it's femoral acetabular impingement. We also have patients with cartilage defects from post-PAO. We have patients with SCIFI and stuff like that, but I'll mainly talk about FAI, or femoral acetabular impingement. And what is that? This is how it looks, or it's like graded in the literature, and you can find these on the internet. It was originally described by the Gans group in 2003, so it's only not a little bit more than 10 years old, this concept. We've known osteoarthritis for hundreds of years. But in this article changed the whole thing. And when you look at it, this is a normal hip. It's like a contained joint with a ball inside a socket. And then you have the pincer. It's over coverage either in one aspect or whole way around on the joint. You can have a general or a focal over coverage. You can have a coxa profunda or protrusia, or you can have an anterior or posterior prominent wall. And pincer means it's just something that grabs. And then you have the cam, which is it's a bony bump or femoral retroversion. You can have the pistol grip deformity and variants of that. And cam is actually something from the engine. It's a camshaft. And you have mixed pathology, and most of the pathologies are mixed. So it's about 70-75% mixed pathology in most reports. So this gives rise to characteristic morphological changes to the cartilage and to the labrum. And in the pincer type, you get a pinching or impingement on the labrum that gives very characteristic changes on the rim, on the labrum. And also you have changes to the chondral labral junction, and that's the junction between the labrum and the cartilage, and that gives rise to the changes on the edge of the acetabulum. And that's why we look, at least why I look at the lateral sourcil, because that's where 95% of the changes will appear in the common FAI patient. So that's why the standing X-ray is so important, and you look for the joint space width. I know it's not the whole truth, but it gives you an idea of, can you help this patient? And this is how a pincer looks on the video. You have a starting to loosening of the cartilage on the edge, and you have a labral tear at the base. And then you have the cam type injury where the big bump squeezes the chondral labral junction. It actually leaves the labrum intact in most cases, but it'll give you a tear, very characteristic tear at the chondral labral junction in the joint. It's a delamination type. And this is how it might look. This is a 27-year-old motocross driver. It's not a good situation for a 27-year-old. Now, back to the opening question. Hip arthroscopy for osteoarthritis, is it doable? Let's have a look at the literature. There's a lot of literature out there. There's a lot of articles, not many of them are high level. And actually, last year we did a short clinical guideline for the Danish Orthopedic Society and for the Danish Arthroscopic Society. And we had a PICO question that said, is there evidence supporting that patients over the age of 40 have the same good result from hip arthroscopy as patients under 40? That made us look at the literature. And we did a literature search, and we found there were 575 articles possible, and we found in the end 6 articles, including one Cochrane review and one NICE guideline from the UK, included in this short clinical guideline. Why it didn't come up? There's something missing. I'll come back to that. One of the articles was by Mark Philippon and Karen Briggs. It was hip arthroscopy for femoral acetabular impingement in patients aged 50 years or older. And they looked at their results, and they came up with if they had joint space width under 2 millimeters, they had very bad results. If they stayed over 2 millimeters, they had pretty good results. And another study was from Ben Dome. And they talked about outcomes of hip arthroscopy in patients aged 50 years or older compared with another group under 30. And they had basically the same outcomes in their scores after 2 years. So the conclusion, that was I was missing before, it came now. It seems that patients over 40 have a good result after hip arthroscopy on pain and function. It's very important that you grade the OA changes on the X-ray, the Tönnis grade, and you look at the joint space width, and you also look for severeness of cartilage injuries. Then it might be a good option. But there are no level 1 or 2 studies at the moment. So we are lacking good studies. Okay, so how much arthritis is too much for hip arthroscopy? And Ben Dorm has done a systematic review on this. And that's based on 13 articles. And he states in the conclusion that current evidence is insufficient to define a cutoff for how much is too much. They say that a Tönnis grade 1 or greater or joint space width of 2 millimeter or less are less likely to benefit from hip arthroscopy. From the Danish registry, as I said before, in Denmark, I think most of us agree that we don't go under 3 millimeters joint space width at the lateral sourcil, and that's a relative contraindication for hip arthroscopy. That's where we look. And we recently did an article on this from the Danish registry from the first 2,000 procedures. A little bit more than 2,000, but it's 2,054 FAI patients. It's unpublished yet. We're still waiting for acceptance, but it's finished, the article. And when we look at the joint space width in the registry, you see that only 6 patients have under 2 millimeters. The majority are over 3 millimeters. And when we look inside the joint, remember, as a tableau, we graded it with the backs and on the head with the ICRS. And in the acetabulum, there were only 27 patients with normal cartilage, and on the head, the vast majority. When you look at grade 4 changes, it's 200 patients with grade 4 changes with bare bone, and only 36 on the head. In this time frame, we had a revision or conversion to total hip arthroplasty under 1%, but it's a very short follow-up. All the patient-related outcome measures in this group improved significantly. In here we use the HAGOS, the Copenhagen Hip and Groin Outcome Score, and the patients get better. There's not much change from 1 year to 2 years. And also with the EQ5D and the hip sport outcome activity scale, there's a significant improvement. So we also looked at, I looked at my old cases from more than 6 years follow-up. This article has just been accepted. And we had 85% we could get in contact with. So they had a minimum of 6 years follow-up. They're all FAI patients. We excluded all the other patients. This is FAI patients. 19% had a total hip in the follow-up period. The total hip arthroplasty group was significantly older than the primary intervention group. They were almost 48, and the other were 8 years younger. The higher the OA grade on the pre-op radiographs, the higher the risk for conversion to total hip. Another group, Ricky Villar's group from Cambridge, they looked into advanced osteoarthritis hip arthroscopies. And they found that in their group, when they looked at the patients with severe OA, Tönnis grade 2 and 3, there were 34 patients, 44% that required a total hip at mean of 18 months. And 56% patients had no total hip after 2 years. So they consider this as a reasonable option. A reasonable option. So it's 50-50. So what's the incidence of total hip arthroplasty in osteoarthritic patient? John O'Donnell from Melbourne in Australia. They had 90 patients, 16% of their participants requiring a total hip. And they found that in patients younger than 55, it was less likely. They said it's a good option. So now we're standing here with a young patient with a grade 4 cartilage lesion. What do we do? This is one. You see normal cartilage in the joint, except here at the classic part in the front. I've done a label refixation. I put in 3 anchors. I did a microfracture. So, does it help doing a microfracture in the hip? That's one of the procedures we can use. And Shane No studied this, and they looked at the outcomes, and they found that there were only small clinical series with promising early outcomes. And this is how it looks when you do a microfracture in the hip. So what are the indications and the outcomes? Ayeni studied this in a systematic review, and they found 12 studies, and they reported positive outcome in 11 of the 12, and a very low complication rate. So the outcomes are in general positive, but again it's low-level signs. And actually Jim Lubowitz posted a commentary on this afterwards, and he said that it's a short-term follow-up compared with the 20-year published outcome from knee abrasion arthroplasty, and he suggests that it might be safer to, instead of doing microfracture, just doing abrasion arthroplasty, because it might fail like it has supposedly done in the knee joint. So there's some promising cell therapies on the horizon. And one of them is Andrea Fontana in Italy. He's done some studies on AMIC procedures, putting in a scaffold. And his results are pretty good, but I think he's one of the few that has published on this subject. So, is there an indication for hip arthroscopy in the presence of OA? I think it is. So, my take-home message is that you have to check on standing x-rays the grade of OA before you do hip arthroscopy. You also have to check the joint space width on the x-rays. And age matters. I think it's probably best to stay under 55. And in selected cases, you can go above that, but I prefer to have the younger patients. They tend to do a little bit better, even though we don't have very good evidence for that. Okay, thank you.
Thank you very much, Bent. I'm not sure that I consider a 50-50 procedure a reasonable option, but we can discuss that. Next speaker, Kjeld Søballe, my former PhD supervisor and a friend, who will be talking about hip dysplasia. Thank you.
Hello, my name is Kjeld Søballe. I'm a professor at the University of Aarhus, Denmark, and thanks for inviting me to give a lecture on hip dysplasia. I've been working with hip dysplasia for about 20 years now, and I'm happy to share with you some of our experience with this disease and the treatment. My patients are pretty young, between 28 to 30 mean age, and most of them present with a C sign, pain in the C sign area. That's what we call C sign. It looks like a C, and it has become a quite popular term. So patients with the C sign, pain and also pain in the groin, we'll always expect that it comes from the hip joint. So we'll always take an X-ray, as Ben mentioned, and it have to be a standing X-ray. It's very important to evaluate the acetabulum. Then we'll always measure the C angle, and we'll identify the circle around the femoral head at both thighs, and then we'll find the center of the femoral head. And then we'll make a line, horizontal line and a vertical line from the center, and then the third line would be from the center towards the edge of the acetabulum, and then we'll measure this angle. It takes about less than 30 seconds, and still I see patients every week where somebody did not measure the C angle, and the patient never got a diagnosis. It's a terrible thing, and I hope that it'll be better in the future. But we call this angle C angle, center edge, and if it's less than 25 degrees, the patient has dysplasia. And if the patient has pain, we can move on with surgery. Before we do that, we will of course do clinical examination. We'll do the impingement test and the FABIS test, as you probably know, most of you. Impingement test, we'll flex the hip, an internal rotation, adduction, and if the patient has pain in the groin, the test is positive. Next test is a FABIS test, where we'll again flex the hip, external rotation, and push the knee towards the floor. If the patient presents with pain in the groin, the test is positive. Indications for PAO, as we call it, peri-acetabular osteotomy, is of course pain. We don't operate on patients not having pain. C angle less than 25 degrees, as I just showed you. Good joint congruency, good range of motion, non or mild osteoarthritis, and age between 13 and 45, maybe 50. That's the indications. We have been using several approaches over the years. We started with cadavers 20 years ago, and then I started with an approach called Smith-Peterson. Then I changed to ilioinguinal approach, then back to the cadavers, and finally we came up with a minimal invasive approach I'll show you today. This is the right hip joint, and you can see we are dealing with some quite interesting structures here. We have the arteries and the nerves and the muscles. And the first approach is ilioinguinal, so we just move on and go into the joint, do the operations from this approach. It's a little dangerous. This is another approach you can use, but there are a lot of complications using these approaches. So we finally came up with this small approach, which we use nowadays. That's how it looked in the beginning, and now it looks like this. So we have changed it, which is an advantage for the patient. Now, dealing with the new way to do surgery, we have to deal with the osteotomies, because we have to separate the pubic bone with the chisel. We also have to deal with the ischium and ilium. And again, we have the nerves, the femoral nerve, the sciatic nerve. We have the artery and vessels. So I actually came up with a small incision coming from the anterior superior iliac spine towards the center of the hip joint. And it's actually possible to cut all the three, to do all the three cuts through this skin incision and perform the osteotomy. The whole secret about the osteotomy is that the posterior column is intact. If we just remove the acetabulum for a while, you can see that the posterior column is intact, and that's so important. That's why it's so stable, that we only need 2 screws to fix the fragment. And the patient can mobilize same day, and they normally go home the day after surgery with 30 kilograms of weight bearing for 6 weeks. The patient is in a supine position, and these instruments, it's a pretty simple set of instruments. The only instrument I had to buy was this 30-degree angle osteotome. Otherwise, we had all of it in the OR. This is the incision, about 7-8 centimeters long. And we start with the anterior superior iliac spine. And open up the fascia. There's a cutaneous nerve which we isolate. It's always just in the middle. And most of the patients will lose the sensitivity on the anterolateral part of the femur for the first 6 to 12 months. Then we take an instrument and run it along the medial aspect of the ilium. The first cut is the pubic. We have a protector behind the pubic bone to protect the obturator nerve and artery, which is just behind it. So when the chisel penetrates the bone, we avoid cutting the artery and the nerve. It looks like this. Divide the pubic bone. We have the vessels and the nerve medial to the osteotomy. And this is a slightly curved osteotome I'm using. And it has to be done completely. That was the pubic bone. Next, the cut is the ischial bone. I use a large pair of scissors to get access to the ischial bone. Just running along the anterior part of the femoral capsule. And then the angulated osteotome is advanced between the scissor and the bone, just along the capsule, all the way down to the anterior part of the ischium. Then we do X-ray. We have an image intensifier, so we can control that we are just where we want to be, and then we can go ahead and do the ischial cut. It doesn't go all the way because we are maintaining the posterior column, so it's only about 1.5 centimeter deep. Then we move the chisel to the medial part and complete the osteotomy. Here we have the sciatic nerve, which is also in danger. We have only seen a single patient with the problems with sciatic nerve, so it's doable without damaging this nerve. Then we move on and do the medial part of the osteotomy. And the last part is the ilium. This is the only one we actually can see. And it's done with the oscillating saw, cutting all the way down to here. Then we just need the posterior column. It's just a straight osteotome, also controlled by X-ray. As you can see here, we have a hip joint here, the posterior column here somewhere. So the chisel goes right between these two structures, and then all the cuts are performed. Then we can do the redirection, doing an adduction. It's actually a 3D redirection. so we can actually also give a better coverage anteriorly or posteriorly as we want, depending on the case. We spend about 3-5 minutes to get the best coverage, and then we put in the 2 screws, and we're done. The operation takes about 1 hour, so we can easily do 3 cases per day. Of course, there are a lot of potential complications. We are close to the nerves and arteries, and you can also see secondary displacement and non-union and infection and so on. We have a database, and out of the first 1,612 operations, we had 3 femoral nerve pulses. It was fortunately only temporary, so they all came back again within 3 months. We had 1 temporary peroneal palsy, also came back. We had 2 secondary displacements. We have to redo 1 delayed non-union, and 1 superficial infection. So it's less than 0.4% complications. We have published quite extensively on this topic, dysplasia. We have published 4 PhD studies and 3 doctoral theses. So we have a lot of data, and we know much more about the indications and also how to do the surgery compared with when we started 20 years ago. We have been dealing with epidemiology, radiology, MRI, PET, surgical approaches, long-term results, risk factors, navigation, and morphology of the hip joint. And we have published about 30 papers, actually 45 papers on this topic. One of the papers I'll just show to you. It's just finished, and we're dealing with the Haddad score. You probably know it, groin pain, and we looked at pain. This is pre-op, 3 months post-op, and 1 year. Pre-op, 3 months post-op, 1 year, and so on. And you can see pain is significantly improved, symptoms significantly improved, ADL close to normal. Sports recreation is also significantly improved, from 40 to almost 70%, and quality of life also increases significantly. So that's what the patient can expect when they ask us, what can I expect from the operation? We can tell them, based on these data, that they're getting much better in all the parameters. So they can expect to relieve pain, improve function, increase sports activities, improve quality of life, and also delay or prevent osteoarthritis, which of course is on the long-term run. Length of stay in hospital. The first patients I did were in hospital for almost 14 days, and now 95% go home after 1 day. It's also because we changed the way we do the operation, and we do a better rehabilitation and so on. Volume is important. That's also why we can do it much faster than in the beginning. Nowadays, we do about 200 cases per year. I just brought a few studies I'll show to you, published 10 years ago, where we did CT scan of patients pre and post-op and measured the coverage. This is the femoral head, and the orange area is the acetabular coverage of the femoral head. Because of dysplasia, the patient lacks coverage on the lateral part of the femoral head. This is pre-op. CT scanning post-op showed that we could increase the coverage from 54% to 87%. And that's probably the reason why the patient is getting better. The area is much larger, and thereby the load is much smaller on the hip joint. We have done a recent study on 462 hips, follow-up of almost 8 years. Failure was conversion to total hip arthroplasty, which is relevant. We looked at several factors. I just summarize here. Age is important. If the patient is over 45, we have more conversions to total hip. The pre-op CT angle, that means severe dysplasia, also is a risk factor. Post-op CT angle, that means how well did we do the surgery, is also important, of course. Of course, arthrosis, as Bent also mentioned, is also a risk factor for this operation. The approach is important. After we developed the minimal invasive approach, we have better results compared with the earlier approaches. The degree of osteoarthritis is important. 20 is definitely the best patient. 1 is okay, but 22 is not good. And 23, of course, we should never do. So we try to stick to 20 to obtain the best results, of course. The correction is important. The better we can correct the acetabulum, the better results. Anders Troelsen did his PhD in our group some years ago, and he measured all these parameters on the X-rays. He spent so many hours and days and months measuring X-rays. The good story is that we don't have to do it any longer because it doesn't matter. The only that matters is the C angle. All the other ones does not have any effect on the outcome measures. So, predicting outcome, severe dysplasia has worse results. 20s over 1 we should not do, and joint space width is also a risk factor. Age is important. If the patient is more than 45, maybe 48, we will probably do a total hip instead of. And our job is to do a good correction, which we of course do as much as we can. I have just one example here. It's a 28-year-old female, severe dysplasia on both sides. We did the left one about half a year ago. Here you can see the pubic cut, the ischial cut, and the ilium cut. If we take if we enlarge it a little, you can see that we have moved. First of all, that's what we look for during surgery. We look for this angle, acetabular index angle. We look for the C angle before we put in the screws. We look for the anterior and posterior column. We look for the ischial cuts. We move the ischial bone a little medially. We also look for the pubic cut. We like to overlap it, so we like to medialize the whole acetabulum to reduce the load in the hip joint. And then we put in the 2 screws when we're happy with the precision. This is the metal clamps. What about labrum? In a normal hip, you have a pretty low load on the labrum, but if you have a dysplastic hip, the load increases significantly. The increased load forces due to insufficient acetabulum coverage. When the patient has dysplasia, the chronic overload will result in labral degeneration, tearing, and destruction of the cartilage. That's what we know. So when the patient mobilizes, we'll risk to get a labral tear, and then we are in trouble. We did just finish this study where we MRI scanned 104 patients. 96% had labral pathology. So from now on, we don't do MRIs any longer. We regard all our patients with dysplasia as they have a labral tear. We did a classification of the labrum, and we divided the patient in 2 groups, moderate dysplasia and more severe dysplasia, and we found labral tears in almost all our patients. And there was only small differences between what we call the borderline and the more severe dysplasia. Even the 3B was present and 3A was present in the borderline dysplasia. So from now on, we regard all patients with C-angle less than 25 as dysplasia, and we recommend the operation we are doing, the PAO, instead of arthroscopy. Because it has also been an option, should we do arthroscopy in dysplastic patients? We don't think so. We just had a seminar at the Danish Orthopedic Society half a year ago, and we are now writing up guidelines about dysplasia, and it was concluded that hip arthroscopy is not indicated in hip dysplasia. That means C-angle less than 25. Instead, the patients should be referred to a center where this operation can be performed. If the patient still has problems with the labrum, arthroscopy can be indicated. So in conclusion, the minimal invasive approach for PAO represents a safe technique. It's a tendon sparing. That means we don't take off rectus femoris as they did earlier. Few complications, 0.4%. And survival rate is 91% after 8 years. The operation time is short. Blood loss is low, 250 cc. Transfusion rate is low, 3%. And length of stay in hospital is short, about 1 day. Thank you very much for listening to me.
Thank you, Kjeld. It looks so easy when you do the surgery, and I'm sure it's not. So. And last but not least, Professor Haddad, all the way from London, will talk about the final option, which is hip arthroplasty.
Thank you. This is the wrong talk. This was the previous talk. If you go into the other session, this was the previous session. Bear with us a second. I'm the bad guy. They've been preserving the joint. I'm about to ablate it. So this is purely destructive surgery coming up. I was until about 2 weeks ago going to talk you through our FAI data, but I discovered someone much better was going to do that. So I'm going to talk more about what happens when it all goes wrong. If all else fails, I'll give the ACL talk again, because that was relatively straightforward. It's fine, don't worry. This is when I normally call my children.
Question for Bent. When you have a patient with a femoral acetabular impingement, often the disease is bilateral. So when you look at the X-ray, you would have a symptomatic hip on one side and you see cam impingement on the other side. What are your thoughts on prophylactic surgery?
I think most of my colleagues here will agree that we only do surgery on symptomatic patients. So, and actually we don't know why some patients have symptoms only from one side, and the hip on the other side looks even worse. And I don't think anybody knows why, but I think both here in Denmark and internationally, people won't do prophylactic surgery, not as far as I know.
Thank you. And on to Dr. Haddad.
Okay, thanks. I'm sure we're going to come back to those questions because there's lots of areas there that are unexplored, including combined dysplasia and impingement and what you do with those. So hip arthroplasty, I thought I'd give some disclosures here only on the basis that I've done a lot of development work. So particularly I'm going to talk a little bit about resurfacing. I don't get any benefits for resurfacing, but I thought I'd mention that I'm eternally conflicted. So the reality is, I think we would all agree that the best joint you can have, not just in the hip, is your own joint. That's the one that works best, and that's the one we should try and keep. So the first two talks are the important one. I'm just a little bit of entertainment at the end. But the reality is sometimes happen. But when you come to hip arthroplasty, and uniquely to the hip, although it's the final option, it really is not a very bad option. If you had to have one joint fail on you and have an arthroplasty, you would choose your hip, because hip arthroplasty is an amazing operation for the majority. So I don't think I need to sell you that. I'll talk to you about some of what we do with that. But the real question for me is how we get high-level function, how good we can get, whether we can do sport, and whether it will still last in spite of that. Because the reality is there's lots of hip replacements going in worldwide. They're going in younger and younger patients. There is not a week that goes by that there isn't someone under 40 on our operating list for some form of hip arthroplasty. And the reality is those patients who are young and active are at greater risk. So those cam impingers doing their football, doing their sport, are coming to us at the end of their professional careers with very badly damaged hips and getting early arthroplasty. And so as a result of that, we've got people with incredibly high expectations coming to arthroplasty surgery. And so we need to get it absolutely right for them and limit the risk of failure. And I would admit at this stage that we don't have the perfect solution, although the solution we may have is probably a little bit better sometimes in the outcome that we get from impingement surgery. So if we look at our impingement patients, they do well, they're happy, but a lot of them still have pain. If we look at our arthroplasty patients, they're disappointed they have an arthroplasty, but they often have no pain. But patients want to be active, even through the ages. They want to be normal, and they're encouraged to expect it. So one of the interesting things for me is how patients now decide. I don't know whether you have this problem in Denmark, but we do in the UK. They've taken away my animation, so this should have come in bits. But the reality is that in the past, what used to happen is you as the surgeon used to look at the peer-reviewed literature and advise your patient. Now the patient is advised by the media, they're advised by industry, and they tell you what they want. So patients with osteoarthritis will come in telling us that they want an arthroscopy or telling us they want a specific type of hip replacement. So the challenge, when these guys can't fix the problem, is to give you a hip arthroplasty that you can forget about. So the idea being that a year after surgery, my patient no longer thinks about their hip, they can just get on with their life. The real dream, that happens quite a lot, so that's not such a difficult thing. But the real goal I have is that the patients in whose hips we intervene with an arthroplasty never come back for another operation. And intuitively, in terms of the technology we have, it should be possible for some patients to do that, because we can get metal and bone to bond, we can get ingrowth, and we have amazing bearing surfaces that can work very well. But we still don't do it for everybody. So what we're trying to do now is give patients back quality of life, and for a lot of patients, quality of life is sport. So we've tried to look at that. We talked, for those of you who were here in the ACL's session before, about how we measure activity and how we measure success. And the reality in arthroplasty, lots of people measure success in terms of whether someone has another operation. For the group in this room, I suspect you're much more interested in activity, in sport, in what people do. And that's what we've been trying to look at. In reality, what we want to know is what people can do, how well they can do it, and whether they're happy and comfortable doing it. That is success, as opposed to someone saying, you've done a horrible operation on me, I'm not coming back for another one. So they're two completely different things. So we've been working hard over the years to develop some scoring systems to really look at people's activity levels after joint replacement and make sure we understand what they do. I'm not going to bore you with the details because they're all published, but we've got these scoring systems that don't have a ceiling effect effectively to see what people can do when they're exercising after surgery. We've gone through the usual tedious iterative processes whereby people spend years working through this and come out with 5 exercises in the hip: single leg stance, stair climbing, lateral step ups, forward frog jumps, and sideways frog jumps, to be able to discern the people who can do things from those who can't. And we've published our validation where we looked at young patients, older patients, and different types of implants, And basically, at the risk of boring you to tears, showed that the younger patients do better than the older patients, and they do much better than those who have osteoarthritis untreated with no floor or ceiling effect. Why am I boring you with this? I'm boring you with this because I'm about to show you some data to show how arthroplasty works. If you want to know more, there's a lot of work that we've done on this about trying to define how to measure function. The other thing we do now, which you may find interesting in terms of what to do, is we get people on a force plate treadmill and really look at what they do after arthroplasty. So we can measure lots of variables here, some of which are unvalidated, but the reality is that doing gait analysis is really quite interesting. You can see what people can do pre-surgery and post-surgery. And it's the sort of thing where you may fix their impingement or fix their dysplasia and see how they function, but they still have deficits on that side, and then you do their arthroplasty and you see how it changes. So we can really track patients very nicely and find out what they do. And look at the forces, look at their contact time, look at their speed. One of the interesting differentiators we have is if you look at how fast people walk, that really tells you how happy they're going to be with their joint replacement, particularly if you put them up and down slopes. That's the toughest thing. If you look at people doing sport after arthroplasty, there's really very little out there that's useful to guide us. Many of you, if you have your joint replaced, will still want to run, jump, play your sport. The guidance is pretty limited, and there's conflicting results between the hip and the knee, because if you have a knee replacement, you really can't do that much. If you have a hip replacement, you can do quite a lot. There's one paper from one of the centres I trained in Vancouver, and what they found is that patients who were active beforehand, who were young, who were male, and who were big, tended to be much more active post-operatively than others. The study is quite a big study, and what they found was quite interesting, is that the hip and the knee were very different, and patients did less as they got older, and they were worried that they have an artificial joint and that they would damage it. And that's one of the big issues here, because young patients, active patients, want to be active after arthroplasty, but they don't do it because they think they're going to damage their joint. So the key question, and one we alluded to earlier, is if you have your joint replaced, how long will it last, and does sport make it fail even earlier? And that's a question we haven't answered yet, but it's something I'm going to come back to in a minute. Because if you go back to my old friends, the registries, and we've heard about the non-arthroplasty hip register, if we look at the arthroplasty registers, what you find is that the conditions that lead to young arthroplasty, AVN, DDH, and young OA, which is almost inevitably impingement or post-trauma, all have the highest failure rates of arthroplasty. So there is potentially a problem there we have to solve. So what do patients do now? So I'm going to talk to you about one study that we did where we compared hip resurfacing, which is now relatively discredited because of the whole metal-on-metal issue, although we're still doing it in young, big males under the age of 65, and hip arthroplasty. This is published for those of you who want to go into the detail. It's a 10-year study of patients 55 and under. The details probably aren't critical for you right now, but it's only 80 patients, so it's not a very big study. Age range 29 to 55, so some of them really very young, and again, single surgeon, straightforward approach. And we've looked at various metrics like implant position, which are pretty good, and we've looked at a whole load of perioperative metrics to show what they're like. Now, this is one interesting finding for those of you interested in outcomes, is when we looked at them, the resurfacing arthroplasties where we took less bone away looked better in the standard scores at 6 weeks, 3 months, and 6 months, but then looked no difference in quality of life afterwards. That's what most people have found. Then we did something really interesting. We started getting them to do functional things. We started getting them to hop, to stair climb, started timing them, and we found some differences that the scores missed. And that goes back to the issue of how you measure outcomes and how you look at it. So when you stratify the groups and get them together and start looking, this is a very busy table, but it shows you what we get for our normal controls. These are people with normal hips. Then you get the hip arthroplasties. They're pretty close, but they're not quite the same. And then you get the BHRs. Again, on the standard scores, there's not that much difference. We're doing pretty well for normal age-matched controls. Then, if we get them onto the more functional tasks, there's a normal joint, there's the total hip, and there's the resurfacing, and you can see the resurfacing is much closer to what the normal can do. And we've seen that on the treadmill as well, in that our resurfacings tend to walk faster up and downhill than the standard arthroplasty. It's a fairly subtle difference, but it's interesting. It may be a historical difference because resurfacing is largely being killed by the metal-on-metal problem. But our scores for the resurfacings were definitely higher. The reason I presented this study is just to show you what really happens after arthroplasty. So you take this group of young patients and put them through surgery, and of the resurfacings, 49% are still running at 10 years, 85% still doing sport, and 18% are still doing manual work. So that's a pretty impressive number of people doing a lot of activity after their arthroplasty surgery. So if it's the end of the road, it's not such a bad end to the road because you can still be active. I didn't want you to go away thinking that people should have hip resurfacing. There are lots of people, including people in this room, I suspect, who are passionately against it because there is a metal-on-metal issue involved. As I say, we still do it, but there are a number of other bearing options. The real key message here is that with arthroplasty, particularly arthroplasty aimed at younger patients, you can actually be quite active afterwards. The last thing I wanted to talk to you about is what our patients perceive they can do and why. So we looked at a big cohort of our patients with at least 2 years follow-up and actually asked them what sports they did, what sports they used to do, and what they can do. We looked at typical scores in terms of their activity levels, and we gave them an activity questionnaire to actually really look at what they got up to. These are slightly older, mean age 55, and then one of our physios had great fun. She did a qualitative review with 64 of them, which actually took a good part of a year to actually sit down and really go through the detail, to look beyond the numbers at actually what the patients actually did. Their baseline scores are pretty much what you expect, so I'm just going to skip through them. They essentially all improve to a certain extent after arthroplasty. And then we'll look at what actually happened. And this is busy, but some of it is surprising. So if you play golf, you go back to playing golf. Some people seem to take up golf because the patient in the bed next to them plays golf after replacement. The really interesting thing for me is lots of the cyclists weren't cycling outside after their joint arthroplasty because they wanted to protect it. And those who came and had their arthroplasty because they wanted to run tended to continue running afterwards. So some fairly surprising findings from that point of view. Most patients are very happy with their joint replacements. They're satisfied or highly satisfied. They would recommend someone else have one if they had one. And they think it's important that they can carry on with the activities that they wanted to carry on with beforehand. But they're often not doing it as often as they did it before. So 2 or 3 times a week, 4 or 6 times a week, very few doing daily sport, and some doing it just once a week. If you ask them how well they can do their activities, most of them are doing a lot better, some of them slightly better. So you can do sport and feel better after your arthroplasty than you did before. And this was the key one. Are there any activities that you no longer perform, and what's the reason for that? And there are some that perform them as normal, but very few actually don't do things because they have pain or a problem. The majority don't do things because they don't want to stress their joint replacement, because their surgeon has told them not to do it, because their physio or somebody else has told them not to do it, or because their friends, because of course their friends are the experts, have told them that they mustn't do it at a coffee morning or in the pub. So at a minimum of 2 years after joint replacements, all patients who wanted to return to some form of athletic activity. That's really quite reassuring. We see high joint and activity-specific scores. So although it is the last option here, and they're the good guys and I'm the bad guys, my guys are still doing sport, so it's not so bad. Most of them are very satisfied, and patients are pretty much doing the sports they want, except they seem to be giving up outdoor cycling for one reason or another. So I just wanted to summarize. Arthroplasty may be considered the last option, but actually, guys, it's an amazing operation. It's longer lasting than FAI surgery, which will eventually fail over time. PAO surgery still doesn't, to my mind, give you an equivalent improvement in quality of life. I think it's an amazing operation that Kjeld does incredibly well. But in terms of quality of life improvement, we've not seen that same as arthroplasty in young patients. They often still have residual symptoms. They're often still slightly restricted, and we can probably argue over that in a moment just to challenge you a little bit. We're doing arthroplasty more and more in younger patients. They're a different group from the ones the guys are preserving. They're the ones the guys that can't be preserved, but they do very well. They can get back to reasonable activity. And the big message is that I think sport is possible, but actually we as a community need to actually understand what we want to tell patients they can do, because they're still confused and they're still listening to their friends rather than listening to us. So the key issues are giving people back function, and I think arthroplasty gives people back very good function if we do it well. Thank you very much.
Thank you very much, Ferris. If we can have the faculty come up here, and we'll have time for questions. And now you will take away my microphone. Thank you very much. I'll continue with one of your final slides. You've shown how much sporting activity the patient returned to. All three of you presented 3 different surgical procedures. Can you each comment on what are the restrictions you give your patients, if any, and when do you allow them to come back to sports, including high contact sports? If we just start with Ferris and go all the way down.
I have to press. So they do whatever they want regardless of what I tell them. So I make a pact with the patients that for the first 3 months they will do no impact activities and they will restrict their range. And after that we pretty much let them do whatever they want to do.
Including downhill skiing, anything?
Absolutely. In fact, until this year I've always been able to say that downhill skiing is perfectly safe, and we've just had someone come back with a dislocation from downhill skiing. So I'm very upset I can't say that anymore. But they couldn't do it in Denmark, apparently, because it's pretty flat.
Thanks.
There's no downhill skiing in Denmark, I think.
That's what I worked out. I worked that out today.
Well, our patients, they are mobilized, as I said, same day actually, and sent home next day, and then they're allowed 30 kilograms of weight bearing for 6 weeks. Then we see the patients and take an x-ray and to make sure that the bone is healing, and then they're allowed to increase the weight bearing up to full weight bearing after a total of 8 weeks. Then we don't see them. That's the only time we see them actually post-op. But they can still call us, and if they have problems, we'll take them in and take a look at them again, of course. In terms of sports, I normally recommend that they try, if they want to run, they try to run, but they start very slowly. They start to walk the first 2 months, and then they slowly start to run, maybe run 1 minute, walk 1 minute, to test the hip. If they feel pain, they reduce the activity, and if it doesn't help, they should probably not run. They should do something else. Then they can try biking or walking or golf, or so they sort of try, and if they succeed, they can do it. If they have pain, they should not do it. That's pretty easy to live with and easy to tell the patient. Skiing is no problem, I think, because they flex in the hip, and that's actually pretty. Most dysplastic patients, they like this position, flexing a little bit in the hip, because they're sort of making the dysplasia less severe, because they have better coverage posteriorly. That's at least what we think. Yeah, that's more or less our way to do it.
Ben, how about you? Anything goes immediately, or?
Excuse me?
Does anything go immediately, or do you have restrictions for your patients?
No, when I started out, we did non-weight bearing or 20 kilos, but now I saw John O'Donnell's patients. They are Australian rule football, and some of them are back playing Australian rules after 6 to 8 weeks. So our patients, they are recommended to use crutches for 2 weeks with weight bearing as tolerated. Then if they can let go of the crutches. Recommend that they start running on a treadmill about 2 to 3 months, and then they can start running outside after 3 months, and returning to sports with the pivoting and stuff like that after 5 to 6 months.
Thank you. Are there any questions?
Hi, I sit here both as a physiotherapist working with people who have total hip replacement and as a patient of Ben Lund's 4 years ago, so very involved in this. Mr. Haddad, you said as the last, we have to agree on what we recommend, and you also showed numbers that showed that actually some patients do follow our instructions. And then you, in this short answer, said that they can do whatever they want. Is that your official restrictions in like the brochure from your hospital after 3 months?
They're very lucky if they get a brochure in my hospital, but it's, no, I mean, in reality, you've got to be careful. What I think I said, or what I hope I said, is whatever I say, patients actually typically will end up doing what they want. If they ask, and if they're willing to listen, what we talk about is the fact that they have a bearing surface. So we typically, in a younger patient, believe that we can get ingrowth into the components either side in the hip very reproducibly. So the challenge we face is that they're testing a bearing surface which will probably wear out over time, and we just tell them that. So the volume of activity they do, any extremes, any edge loading, or any impact is going to be bad. And actually that's what, the brochures will say that, and that's what we tend to tell them. The reality beyond that is they will do what they want to do.
If I can elaborate on that, we did a study at Hvidovre, and up until 2 years ago, we had restrictions for total hip arthroplasty patients with the usual restrictions that they're not allowed to flex the hip, abduction, and so on. And we did a study and looking at the reasons for dislocation, and we actually found out that the patients, they don't listen to us, they do whatever they want to. And after we abandoned the restrictions, we didn't see any increased risk for dislocations, and over half of the patients that dislocate because they fall or they do some unexpected movement, so we don't believe in giving any restrictions.
We have the same protocol in our place. We even allow our patients, our total hip replacements, to drive a car after 2 weeks. There's a recent study from United States where they did a study, and the only thing the patient have to do is to move the foot from the speeder to the brake in faster than 1 second. And it's doable after 2 weeks. So we allow our patients to drive the car after 2 weeks. Because, I mean, patients are so dependent on the car. And it's really a problem that they cannot drive the car for 3 months, for instance. So they're pretty happy about our new system.
And I mean, I think dislocation precautions are really not applied very widely anymore, except in high-risk patients.
We did a study at the last Danish Academy meeting, and less than 50% of the surgeons used restrictions. So there's definitely a change in the regime there.
Finn Johansen, being a rheumatologist, I'm pretty impressed of the results by Kjeld Søballe of this operation here. I wonder, this 25 degrees CE angle, how strict is this? Will you not operate on a 26 degree, or is it all 24 degrees should be operated on? Or is it so that the moderate dysplasia could maybe have benefit from another therapy, maybe physiotherapy, before you think of the option of going into operation?
That's a good question. The normal CE angle is between 35 and 40. And for some reason, 25 came in. It's actually from 1937 from Sweden. There was a Swedish professor who defined dysplasia at that time, and that's the angle we still use. So, I mean, if you have a patient 26, we wouldn't mind doing a PAO if the patient has classical symptoms. But, you know, we have to get a pretty final number or grades, degrees before we can move on. If the patient can benefit from physiotherapy, I haven't seen any studies, but we're doing a lot of research now on dysplastic patients. We actually had 2 physiotherapists working with dysplasia and FAI at the moment. So I think within 2-3 years we have much more knowledge about if there's an alternative for some borderline patients maybe. But so far I haven't seen any publications. Maybe you have some.
No, I'm awaiting for these studies also randomized. I just wonder, what is the incidence of being below 25 degrees among the normal population?
Yeah, we know that actually because the first doctoral thesis we made was on epidemiology, and it was from the Copenhagen study. We had, I think, 4,000 X-rays from the Danish population, 30 years old. And from this study, we could see that 5% of the Danish population has dysplasia. That means C angle less than 25 degrees. 5%. But not all the patients have symptoms, of course. We probably only operate on 1% of the dysplastic hips, but 5% in Denmark has dysplasia.
Can I just ask you a quick question? I kind of think of it as coverage rather than the angle would be the right answer.
Yeah.
Do you have a proportion of patients who have a CE angle that's more than 25 but have anterior uncoverage that are symptomatic that you end up having to do something for?
Yes, we definitely do. I mean, dysplasia is a very complex thing. You can also have retroversion. I mean, you can have problems with too much coverage anteriorly and too much posteriorly, so there's so many variations. And in this case, we'll probably do a CT scan and look at the three-dimensional. And we also do reverse PAO, where we actually we turn the socket opposite as we normally do to reduce the coverage anteriorly and increase it posteriorly. So there are so many ways to do this operation, and we get more information every single day due to our experience.
Can just say a little bit, it's because it's a gray zone between osteotomies and hip arthroscopy, and it gives rise to some legal issues as well. If you do a arthroscopy and do a rim trim on a patient that has a slight anterior undercoverage, but maybe has a normal CE angle, and it's so we like Kjeld says, we have to study that, and the CE angle or the AI angle is not enough. We have to do more like 3D studies to define this gray area. If you have a patient with a CE angle of 15, it's obvious, but in this zone between maybe 20 and 30 degrees, it's a variation with the rotation also, retroversion, anteversion, and all that stuff.
I mean, maybe the key thing, is because I'm talking about the wrong thing, but is that groin pain in a young patient is a problem that should be characterized. I think that's the biggest challenge still in the UK. I don't know what it's like in Denmark, but in the UK, lots of these patients don't have access to that expertise. They're wandering around the community with groin pain. They fail physiotherapy, they reduce their activity because they've got groin pain. And it's actually getting a diagnosis. It's not necessarily getting an operation, but getting a diagnosis is important.
Yeah. There was a question down there.
Thank you very much for the presentations, all three of you. My name is Thomas Linding Jacobsen, and I'm a research and development physiotherapist at the Copenhagen municipality. I got a question for you, Bent Lund. It's about the hip arthroscopy. The first question is about what kind of procedures you do in the hip. That's one thing. And now, early this morning, we talked about sham surgery. Are there any procedures about hip arthroscopy and hip sham arthroscopy in the randomized controlled trials in that area? And also, before you do the procedure, have you done any kind of pre-rehabilitation to see that could relieve the problems before you do your hip arthroscopy? So that was 3 questions. Hopefully that's all right.
Let's take the first one. It's what I do when I have of course we address the morphological changes. We address the FAI, the pincer, the cam. We repair the labrum with maybe suture anchors. or debride it, and we stabilize the cartilage. Regarding the sham surgery, we just put in a application for the ethical committee in Denmark. We do a multiple center study with Oslo and some Canada people and Australian people. It's going to be a randomized controlled study with sham hip arthroscopy for FAI and sham surgery. I know there are two studies going on in the UK. Damon Griffin's group and another group studying, but they're looking at a surgery and physiotherapy. So there are no randomized study out there that we have in the knee joint. This sham study is starting in Oslo now. We were still awaiting for our approval from the ethical committee. It's quite interesting. And for the last question, I've forgotten what you asked.
That's about the pre-rehabilitation.
Yeah.
Before they actually.
Most of the patients coming to us have been through all kinds of rehab. The problem is, and that was something that Julie was supposed to talk about. Actually, not very much is known about how do you. What's the right kind of physiotherapy for these patients? There are no good studies out there, and I know that they in Australia, Kay Crossley and Joan Kemp, they have looked into that, and they are part of this group that is starting this sham study. They have developed a physiotherapy program that we are going to use, but there are no evidence that shows that you can heal these patients if they have FAI, but most of the patients have had physiotherapy before they come.
Just a last question about the one about hip arthroplasty and knee arthroplasty, about the guidelines for what kind of activity you can do after operation. Well, still, last time I looked for guidelines, they're still quite conservative, so no non-contact injuries or sports after hip arthroplasty. But I don't know if rugby is all right after hip arthroplasty.
If you watch the World Cup, you know we can't play rugby anyway, so it's it's quite difficult. I mean, in reality, there are very few guidelines out there. If you look at the Knee Society guidelines, there have been two phases. The first one was ultra-conservative, the second one much less, and then it's been stunned silence ever since because nobody wants to put their neck out. And I think every surgeon in the room will know that their patients carry the crutches in for the consultation. They don't use them most of the time outside. And if they do, you know they use them because they've padded the wrists, things. Because if they're not padded, they haven't used them. I mean,
Kjeld and Ferris, could you please elaborate a little bit on the pre-rehabilitation? How much do you use it before you do surgery for dysplasia and hip arthroplasty? Do you require that the patient have a training for 1, 2, 3 months, or is it only symptomatic?
As Ben said, many of our patients, they have already been through a rehabilitation program before they come to us, so we don't do any special. But we have a waiting list, and in the meantime, when they're waiting for surgery, we recommend definitely that they start doing exercises. We have a program. I sent them from my iPhone, so they can go into the internet, and there's some pretty good YouTube things they can look at, and then I recommend them to go to a physiotherapist and help them starting doing the exercises. So they can do exercises for half a year, so they are pretty much in good shape when they come. If they're overweight, they have to lose weight. We don't do surgery on overweighted patients. So BMI less than 25, otherwise no surgery for PAO. 25? Yeah. So if they're about 25, yeah. Is that too much?
I'm out.
No, you're not. No, well, I just read a paper from USA, and they have, it's a multi-center retrospective study that showed that if the patient has a BMI more than 25, the risk for severe complications during PAO surgery is 1,100%. 1,100%. So it's really difficult if in fat people.
Question there?
I have a question concerning FAI. If you have a sportsman having problem with the CE angle and they have pain, but they don't like the idea consulting Professor Søballe, still they have problem with the labral tear, they have pain, you give an injection and there's really good result with the injection, then the question is, would you do the labral tear arthroscopic, or would you say it's just a waste of time?
I think we would, because as I told, we just had a meeting in Copenhagen half a year ago, and all the centers dealing with this the dysplasia were present. And we agreed that if the patient has C angle less than 25 degrees, the PAO operation should be recommended. And it's a contraindication for hip arthroscopy, because you still have the dysplasia, and the patient will, when you mobilize the patient, after 2 or 3 months, the patient will probably destroy the labrum again. And then you had to redo it, and it's much better to solve the mechanical problem, and then you could do an arthroscopy when you have solved the mechanical problem. And it will be the guidelines. We're writing it up now, and that will be the final answer to your question.
The thing is that, as you saw in Kjeld's talk, that 90% of the patients presenting with groin pain and dysplasia, they have a labral tear. When you do the reorientation and do the osteotomy, only a few of them will have pain afterwards. So in those you might do a hip arthroscopy on, but there are other reasons for pain around the hip. It's not only the labrum; it's also the psoas, and it's a huge gray zone there.
So just two further comments. There's a morphological issue here, which is in these guys, in the people with dysplasia, particularly active people with dysplasia, the labrum is much bigger. It becomes hypertrophic. I mean, the guys can disagree with me, but in reality, it's load-bearing. It's much bigger. And actually, if you take that labrum away, it's a disaster. Those patients deteriorate really rapidly. If you repair it, the repair will merely fail. So you're much better off managing them completely non-operatively than sending them down an arthroscopy route, because those are the arthroscopies that do really badly, including people come back with a clicky hip because the hip completely migrates up very quickly, or even there's instability described from those cases. So that's partial labrectomy in a dysplastic hip is a pretty disastrous event.
And I would never do that. There's actually a study out from Mark Philippon in borderline dysplasia doing labral repair and capsular plication, but I think it's with the knowledge I have, it's better that they have a PAO.
The danger patients is quite interesting. In the UK, we've had, like the US, a huge explosion in hip arthroscopy. And it's the guys who have combined dysplasia and impingement. There's a small population. And people go in, they take away the cam lesion, and they see the labrum, and they trim the labrum, and those do really badly.
Thank you very much. If there are no further questions, we're going to conclude. The time is up and everybody's tired. So thank you very much for fantastic presentations.